Hi, everybody. Now we're on our last video for the legal aspects of nursing. The next video will be on clinical judgment because I do think that that is the best way to protect yourself from complaints of malpractice and negligence. So, what is malpractice? It occurs when a professional fails to act as a reasonably prudent person with similar education or experience in the same situation. So, when people are investigating claims of malpractice, they're going to look what kind of education do you have? You are a registered nurse, so you're held accountable by the state nurse practice standards and by the policies of your hospital that govern nursing practice. Um, but they're going to compare you to somebody with similar education or experience. A person with a master's degree and an advanced practice degree is not held to the same standard as somebody with a diploma degree or just an RN. Acts of commission include things that you do, intentional or otherwise. For example, battery. A patient refuses a blood transfusion and then they have a bleeding emergency, and when they're unconscious and unresponsive, you administer that blood transfusion. That is an act of commission. An act of omission is failing to do something that you should do. For example, your policy states that you have to assess vital signs every 4 hours and you do them every 6 or every 8, or you miss one. And it turns out that that patient suffers harm as a result because you did not assess something that was changing. It can be intentional or unintentional. Negligence is unintentional but preventable. Failure to act as a reasonably prudent person, meaning that if you used good judgment, it would not have happened. So an example of this might be somebody who doesn't understand how to use a particular type of medical device and they use it inappropriately and harm results to the patient. That's negligence. If they had enough common sense, they would understand they didn't know how to use the machine, and they would seek guidance from somebody more experienced. Delegation also can get nurses into trouble, and I'll give you an example of that after I talk through the slide. Professional RNs are always accountable. It is the one thing we can't delegate. We can't delegate ultimate responsibility for acts that we give to another person to do. We are responsible for determining that the delegatee, the person we delegate to, is competent to perform the delegated act. Then that person is responsible for carrying out the delegated act safely. If you are a delegatee, it is also your responsibility to speak up when you don't feel comfortable performing a task. So that is your responsibility. If you are supposed to be certified in IV starts, but you know that you're not competent, you know you don't have a certification, someone asks you to start one, you have the responsibility to refuse to perform something that you cannot safely do. The professional nurse remains legally liable for nursing acts that are delegated to others unless the delegatee is also a licensed professional whose scope includes the assigned act. So if I'm going to lunch and I ask another registered nurse to administer a medication at 1 o'clock, they're responsible for the way they administer that medication. And usually we chart that we gave SBAR beginning and end of shift anytime we're handing off care. 5 rights of delegation. Number 1, is it the right task? Is the task appropriate for delegation in a specific care situation? For example, you're giving a blood transfusion. You can delegate an unlicensed person to go down and get that blood, but that person is not responsible for checking the blood with you. So you need to make sure it's the right task. Right circumstances. Is delegation appropriate in this case? So consider the patient's health status, how stable they are, care delivery setting, complexity of the activity, and delegatee's competency and available resources. So for example, you are working in an intensive care unit. Your patient has maybe they're hooked up to a ventilator and they have a chest tube and they have multiple IV lines. A tech in your hospital can do bed care, but maybe not for this patient. Maybe there are just too many things that could go wrong. And so the RN in most critical care units performs most of the care, including routine tasks like bed care. So you have to determine, are you delegating in the right circumstances? Is it the right person? So can the nurse verify that the person delegated to do the task is competent to complete the task? For example, and this happens a lot in hospitals that are short-staffed, you're working in a specialty unit, we'll say it's pediatrics or mother-baby, okay? there's not enough staff on your unit, so they pull from a med surg unit. It should never happen, but it does sometimes. That is more of an employer issue. And if I had that circumstance frequently, I might raise a concern in a shared governance model. But that person, although they are still acting as an RN, their scope of practice as defined by the Practice Act is the same as yours, does not have the same specialized skills in caring for a newborn or pediatric patient or a postpartum mother. They might not know where to assess a fundus in a postpartum client. They might not know the parameters for normal vital signs for children. They might not know where to listen for an apical heart rate on a newborn. So the right person matters when you delegate. You have to give the right directions and have clear communication. That might include identifying the patient clearly. Don't just say, can you go into room 36 and get a blood sugar? You have to identify the patient by name. The objective of the task, why are you doing it? Well, you need to get a glucose because he tends to run low and they're changing his insulin doses. Time frame, I need it done within a half an hour, and expected results, including parameters for when to get you immediately. So if his blood sugar is less than 60, you need to come and find me right away. If it's over 200, you need to come and find me right away. Those directions are super, super important. Right supervision and evaluation. Can the RN or other licensed nurse provide supervision and evaluation of the patient and the performance of the task ultimately? Because you are, again, accountable. So one example that came up in the California State Board of Nursing, and the nurse was disciplined and was forced to do an educational module. She was working on night shift. They were understaffed. Her patient ratio was unsafe. They had floated people from specialty units. She had a patient who needed hourly glucose checks because he was on an insulin drip. She assigned that task to the unlicensed assistive personnel, and that was within the scope of practice for that individual, and they didn't know how to do it. What she did not do was follow up to make sure she knew what those numbers were. She was so busy taking care of other patients and helping the person who had been floated that she never checked back with the tech. And when they looked back at the medical record, that blood sugar was deteriorating for hours with this insulin drip. And the insulin drip should have been turned down to accommodate those blood sugars. The patient ended up having a seizure and becoming unresponsive, and the family did report her to the State Board of Nursing. And she was found liable, even though the tech was the one who got the blood sugar. It was the RN's job to evaluate and interpret that result. All right, informed consent. Unless primary care provider, you don't get informed consent. The primary provider does. They're the ones performing a surgery or another type of procedure. So you can witness it, but you don't explain that proposed treatment, and you are not responsible for evaluating whether that information was adequate. That is the provider's responsibility. So they're liable and you're not if they do not give the right information. But what you are responsible for is determining that elements for valid consent are in place. Is the person competent to make the decision? For one thing, if it's a child or somebody with intellectual disability, you can decide that a legally assigned representative should sign this consent. You are also responsible if that patient has limited English proficiency, making sure that a certified interpreter was used to obtain informed consent. And if your patient changes their mind and they want to revoke that consent, or they want to consent after they refused, they changed their mind, you are responsible for notifying the provider. Issues related to confidentiality. Well, this is the ANA Code of Ethics, and it's pretty similar to what HIPAA states, but the nurse has a duty to maintain confidentiality of all patient information, both personal and clinical, in the work setting, off duty, all venues, including social media and any other means of communication. Kind of covers everything. Nurses are responsible for providing accurate, relevant data to members of the healthcare team and others who have a need to know. That is our issue with confidentiality, very similar to HIPAA. Social media. I've seen a lot of nurses violate this. The NCSBN does approve the use of social media for nurses. They cite a lot of its advantages for personal and professional networking, for obtaining information sometimes from reputable Facebook groups, but it does not support the use of social media to discuss grievances in the workplace, to talk about your patient icks, or bully your colleagues. And it cautions that disclosing any confidential information, including photos about the patients or even photos where patient information is in the background without written informed consent, is strictly prohibited and subject to discipline. Also, don't friend your patients on social media. I don't care how long you take care of them or how much, you like them as people. It is a boundary issue. Please don't do it. I know nurses who have and they haven't gotten caught, um, but it is a bad practice, especially if they're posting something about their health and you comment on it. So think about that. Assault and battery. Assault is the threat to make unwanted physical contact with another person. That includes procedures. For example, you have somebody who's not sitting still for an epidural, and the anesthesiologist says, if you don't sit still, I'm going to have to put you under general, and they make it sound like a threat. That's assault. Battery, making unwanted physical contact with another person, including the performance of procedures that the person has refused. For example, person is a Jehovah's Witness and refused blood products. Patient then has a bleeding emergency, becomes unresponsive, is ventilated, and cannot make that decision, and somebody hangs that blood. And the patient gets the blood even though they made it expressly clear that they refused it. That is battery. Now, most important thing, how do you protect yourself from complaints? Develop strong clinical judgment. Be safe. Practice safely. That is the most important thing you can do. Recognize cues, interpret them, make a plan, act on it. Those are the things. Demonstrate caring and professionalism. People don't like to sue people they like. So with your patients and with your colleagues, um, use your best therapeutic self. Know your employer's policies. So if your employer makes a policy and you follow it and something happens to your patient, you can defend yourself by saying, this was our policy. You can change a policy, or you can work to change a policy with a group of others, but you always have to follow those policies. Do not accept assignments that are outside your skill level. If you get floated to an unfamiliar unit and they want to give you a patient you have no idea what to do with, do not accept that assignment. Don't even take report. Know your scope of practice and stay within those limits. Do not try to go beyond them. Maintain current knowledge, lifelong learning, so that you're aware of what good practice looks like. Be accountable for what you delegate. Carry malpractice insurance. It doesn't just protect you from malpractice lawsuits. Nurses don't tend to get sued as often as providers for financial gain. It will also protect you against state board actions. Maintain professional boundaries with patients and families. Know the difference between being a therapeutic self and being a personal self. Be careful with social media. And document, document, document. Thank you all for staying with me through this presentation.